Hello, I'm Maggie Black.
And I'm Beth Parker O'Brien.
Welcome to Connected Care. We really wish we were in a room with you right now. Unfortunately, COVID-19 had other plans for us. We were trying to do this seminar live for probably over a year and a half, and we kept getting stopped by this virus. So we finally decided we had to get a little bit creative. So we tried to do what we were going to do live in a webinar, which you're about to see. That will allow you to pause it, to talk to each other, and then on the other end of that, we hope to talk to you on a live webinar so that we can answer questions. Once you've seen the video, you can say, okay, that strategy might or might not work with this specific resident. What can we do? And we'll talk with you live.
Great.
Thank
Thanks.
you.
I'm going to start by giving you a brief overview of the Connected Care program, and then we'll get right into it. The program today is divided into 4 parts. We're going to start with disease process, and the goal is to recognize the difference between the dementia subtypes. So we know that Alzheimer's disease is one of the subtypes, but we're also going to talk about the other subtypes as well. Next, we're going to talk about communication strategies, and the goal there is to understand and identify symptoms and the behaviors of dementia, as well as the strategies to manage the behaviors. So that leads us into behavioral management techniques. We're going to learn and demonstrate strategies to prevent or de-escalate behaviors. The goal is, of course, to prevent the behaviors, but sometimes we have to first learn how to de-escalate the situation. We have to understand the situation, and eventually, hopefully, we'll be able to prevent the situation or the behavior from even happening. Last but not least, we're going to talk about mindfulness and resilience. Maggie's going to present tools to mentally or emotionally cope with a crisis, and then the goal is to return to the pre-crisis status quickly. I want to give you a brief background on Connected Care. So a few years ago, we developed this program for caregivers such as yourself who were working in various healthcare settings. Some were in home care agencies, some were in assisted living facilities, and some were in long-term care facilities such as skilled nursing facilities. We had 2 goals in mind. One was to improve the knowledge of dementia for the professional caregiver, and the second one was regarding behavioral management techniques. We wanted to improve the knowledge of behavioral management techniques, but also how to implement them. So the result has been increased ability to manage the behavior somebody is experiencing with dementia, increase the caregiver's self-confidence in caring for the individual with dementia, and I think this is as important as any of them, increase safety for the caregiver, because you know that when an individual with behaviors gets agitated or aggressive, it become an unsafe situation. So this kind of flows into how does this fit with your work at Homestead? All of these things apply. It's going to help you take care of your residents more effectively, more efficiently, and safer once you have more knowledge of dementia and once you have more knowledge of behavioral management techniques. Your role in Connected Care is absolutely vital. We need you to be present. We want you to turn off your phones. Don't be distracted. We want you to participate. Now, we understand that we're not there today, but feel free to stop the video, talk about what you're seeing with your colleagues, ask questions, say how this might help or not help with one of your residents. Be interactive with each other today. There are 2 classes, this one today and the webinar we're going to be scheduling. Now, what's really important is that when we all get together for the webinar, we want you to bring us your questions. pick our brains. We want you to ask us any questions that you might have about behavioral management techniques, about dementia, about your residents. We're here to help you. Now, that last part that says weekly goals videos, that's being kind of worked out right now. And we're probably going to create some small videos that are about 3 minutes long or so, just to help supplement this today, where Maggie and I can present in a format where you can see us, and also where we can show you some of these techniques that we're talking about. We're now going to move on to talk about dementia, what it is, what it isn't, the different disease processes that cause a dementia syndrome. First, I'm going to show you some few slides on Alzheimer's disease. What I'd like you to do is put down your pens or pencils, just watch the next few slides. It's really important that you understand what happens in the brain, how Alzheimer's moves through the brain, and how it impacts the individual's functioning, cognition, and interaction with the world around them. Alzheimer's disease is a slow, progressive neurologic disease that causes cell death and tissue loss. It affects our ability to remember, do everyday tasks, speak, and understand language, as well as affect our mood and behavior. Let's look inside the brain to better understand Alzheimer's disease. Our brain is absolutely amazing. We each have billions of nerve cells in our brain, such as this one. These nerve cells, also known as neurons, connect at trillions of points. Signals across what scientists call the neuron forest create thoughts, memories, and feelings. But these nerve cells are destroyed by Alzheimer's disease. So let's take a little bit closer look and see how that happens within the brain. Scientists don't really know exactly what causes Alzheimer's, but let's talk about the prime suspects here. Now, I do understand that this may be very confusing for some, but hang in there while I explain. Abnormal clusters of protein fragments build up between nerve cells. These are called plaques. Dead and dying nerve cells contain tangles, which are made up of twisted strands of another protein. Nutrients and other essential supplies can no longer move through the cells, which eventually die. Let's watch now as these plaques and tangles move through the brain, destroying neurons along the way. Alzheimer's starts in the hippocampus, where we form new memories. The plaques and the tangles that begin to develop impact our ability for learning and new memories. It begins to spread to the area that we use for thinking and planning, judgment and reasoning. This is the area of the brain Maggie likes to say, what makes us human? In the mild to moderate stages, plaques and tangles continue to kill off nerve cells, impacting speaking as well as understanding speech. The plaques and tangles continue to spread. Spatial awareness, that is, our awareness of our surrounding and our position relative to them, may make people feel more confused and disoriented, impact their ability for activities of daily living. An individual may become more withdrawn, moody, with difficulty handling social situations during this stage. They may lose control of their bowel or bladder. It's often during this time a family may consider admission to a facility such as Homestead Manor. The disease continues to kill off brain cells, affecting behaviors, personality, how we process sights and sounds, and even our ability to walk. Eventually, even the most basic abilities, such as sitting and swallowing, are affected. In this slide, you can see that how in an advanced Alzheimer's disease, most of the cortex is seriously damaged. The brain has begun to shrink dramatically due to widespread cell death. Individuals lose their ability to communicate, to recognize family and loved ones, and to care for themselves. Alzheimer's disease is a slow, fatal disease. Scientists now believe that Alzheimer's may start up to 20 years before diagnosis. So from mild to moderate disease to death may be more than 15 years. Maggie and I are really looking forward to talking to you about this little video and what you thought, what your impression was. To me, it's amazing how Alzheimer's disease moves so slowly through the brain, taking away one skill at a time. And sometimes we don't even notice it in the very beginning. We just attribute it to aging or something else going on. So I'm really excited to hear about what you guys think of Alzheimer's now that you've seen how it moves through the brain. We're going to switch gears a little bit and we're going to talk about the broader aspect of dementia. We know that Alzheimer's disease is one type, but we want to talk about how other types of dementia impact the brain, understand about other disease processes. Most of us start out with a healthy brain. We don't think about these things that we do automatically every day, like walking, talking, breathing, our heart beating, being able to play with our kids or grandkids or make a meal or go to work. Our brain is the command center of our whole body. And until something happens, we just don't think about it. We're going to talk about what the brain's function is next and help us understand the differences between the left brain and the right brain. Now we're going to talk about the left and the right sides of your brain and how they function. I'm going to ask you to play along with me for a few minutes. I know I'm not there to see you, but I'm going to trust that you're going to follow the instructions that I give. It really will help you understand what the different sides of the brain do. Now first, I'd like you to put your left hand on the left side of your head, raise your right hand, and wave. Your left side of your brain just sent signals to your right hand to wave. That's pretty amazing, right? The left side of your brain controls the right side of your body. So any movement that you have in the right side of your body, whether it be waving or moving your right foot or whatever it is, that's the left-hand side of your brain telling the right side of your body to move. But the left brain does so much more. It's kind of like an office. It's about speech, comprehension, math, and writing. The left hemisphere is dominant in hand use and language in about 92% of the people. That's pretty astounding to me. All right, so put that left hand down. And now we're going to take our right hand and put it on top of the right side of our head. The right side of the brain is creativity, spatial ability, artistic, and music skills. So it's interesting about the right and the left side. So the right side controls the left side of the body, right? And so if you've ever had somebody that you've been caring for who's had a stroke and the left side of their body is very weak, then the stroke has actually happened on the right side of their brain and vice versa. So if it happens on the left side of the brain, they may have trouble with speech or comprehension or writing, where on the right side of the brain, they have problems in other areas. Now that we have a little bit better understanding of the left brain and the right brain, let's dig a little bit deeper into brain functionality. I know we did this when we talked about Alzheimer's disease, but we're going to go a little bit more into the weeds because it's an important aspect, not only for Alzheimer's, but the other types of dementias, as well as understanding behaviors and how to address the behaviors for the individual. Now, what you may want to do, and I'll explain how to do it as we go along, is actually put your hand on the part of the brain that we're talking about, and I'll explain how to do it as we go along. We're going to start with the frontal lobe. So this is the part of the brain. If you take your hand, put the palm of your hand right above your eyes, right above your eyebrows, I should say. Spread your fingers over the front part of the brain, and that's the frontal lobe. And so this is the emotional center of the brain. It's home to our personality and decision-making abilities, creative thinking. Why is this important? Because it also commands our executive process. So voluntary behavior such as decision-making, planning, problem-solving, and thinking, reasoning. It also has to do with somewhat with memory, but also attention and language processing. The frontal lobe will become very important when it comes to dealing with behaviors. And let me just give you a very short example. I'm going to guess that when you try and reason with some of your residents why they should or shouldn't do something, they don't understand it or they do the exact opposite. That's the frontal lobe at work when you're trying to reason with somebody. When that's damaged, they can't reason. So we have to find alternative ways to deal with the situation. The next part, look down where that red elephant is. Okay, I want you to point kind of right above your ear. Just kind of put your finger above your ear. That's about where the temporal lobe is. So the functions that are associated with the temporal lobe are recognition, perception, hearing, vision, and smell, understanding language, and learning and memory. So remember in the Alzheimer's video, this is kind of where that all started, right? In the hippocampus, which is in that part of the brain. I'd like you to put your finger on the top of your brain, behind the yellow, kind of where that blue is, sort of maybe a little bit around the crown of your head, a little bit before that. That's the next part that we're going to be talking about. Okay, so next we're going to go up to the parietal lobe, which is in blue. So this is a really important part of the brain because it controls visual functions, reading, understanding language, and sensory comprehension. So what that means is it helps us process what things are and where things are. It helps us coordinate our movements and response to objects in our environment. So when there's damage to this part of the brain, we may have an inability to locate and recognize objects. We may have an inability to understand, even kind of understand the different parts of our body, like after a stroke. We may have increased disorientation and a lack of coordination. Down below, on the right-hand side, you're going to see a seal balancing a ball on its nose, and this represents the cerebellum. It's kind of a purplish brown, I guess. And that's for balance, coordination, and motor learning. Now, really interesting thing about the cerebellum, it's only about 10% of the total weight of the brain, but it has more neurons than the rest of the brain combined. Isn't that kind of an interesting fact? So it's important for coordination of voluntary movement, motor learning, balance, reflex memory, posture, timing, sequence learning. If that part of the brain is damaged, we may have a loss of fine motor coordination, or maybe some tremors or inability to walk. We may have some dizziness or vertigo. So this, again, we might see more in other types of dementia than we might see in Alzheimer's disease. The last part on this slide that I'm going to talk about is the brainstem. To sum it up, it is about all basic life functions. What I mean by that is it regulates cardiac function, respiratory function, body temperature, blood pressure, consciousness, and the sleep cycle. Again, all basic life functions that we need to survive. We're going to move now from how the brain functions to dementia. I'm frequently asked what's the difference between dementia and Alzheimer's disease. It's often thought that the two terms are mutually exclusive, when now we know, after talking a little bit today, that Alzheimer's disease is actually a type of dementia. So what does that mean? Dementia describes a set of symptoms, an umbrella term, so to speak. It means the individual is having problems with memory, problems with doing everyday tasks and language. All of these things that we've talked about so far, and the ones that we saw in the video about Alzheimer's disease. Now, there are lots of different types of dementia, and you're not likely to see all of them. I'm going to address some of these individually because it'll help you understand how the different disease processes impact the brain differently. Then next, we're going to talk about how to manage the behaviors that can happen with these different disease processes. We've actually talked about Alzheimer's quite a bit, so I'm going to make an assumption right now that you are comfortable with how we've explained Alzheimer's, and if not, you can go back and look at the earlier video again. Parkinson's disease is a progressive nervous system disease that affects movement. You may have cared for individuals with Parkinson's that have trouble walking, they fall frequently, or are stiff or rigid, and they may experience slow movement. One characteristic of Parkinson's is that so-called mask face, where the face actually appears frozen. This is due to stiff muscles in the face where they can no longer move. Parkinson's disease symptoms actually differ from person to person. This includes whether they go on to develop a dementia. Not everyone does develop a dementia with Parkinson's. Those that experience a dementia have problems with thinking, reasoning, memory, as well as attention and concentration. It generally occurs as the disease progresses, and sometimes actually really late in the disease process. Some begin to experience hallucinations and delusions, which may be very disturbing as well. According to more recent research, scientists believe that Parkinson's disease dementia is caused by abnormal deposits of proteins called Lewy bodies. These same proteins are found in other disease processes, such as Lewy body dementia, which we're going to talk about next. Lewy body dementia is a progressive dementia caused by the development of abnormal proteins called Lewy body in nerve cells in the areas involved in thinking, memory, and motor coordination. One of the first symptoms is often visual hallucinations. This can be very disturbing to both the individual and the family, as the individual often sees people, animals, or shapes. The hallucinations are well formed and detailed, and they often remember them. Unlike other types of dementia, where an individual might have a hallucination or delusion and let it go, or not remember it later, with Lewy body, because they start so early in the disease process, they often remember them for a period of time. Memory is also impacted. However, different from other types of disease processes, the memory can fluctuate with variations in alertness and attention. And I found that this actually continues throughout the disease process almost until the very end. They have the signs of Parkinson's disease, which can lead to falling. So there are those safety concerns. The other part that's, I think, important to know clinically is the autonomic nervous system is impacted. So blood pressure, pulse, sweating, and digestion can all be affected. Individuals may become dizzy, have sudden drops in blood pressure, and have urinary incontinence. Another hallmark of Lewy body dementia is REM sleep disorder. During the REM phase of sleep, which is the time in which we dream, individuals with Lewy body may be very active, kicking, punching, flailing arms. They may make noises such as talking, laughing, shouting, or cursing. Remember, they're asleep, so how we approach the individual has to be with caution for their safety and ours. One of the things that you might consider is talking to the family, asking if this occurred at night, and to see if the person was very active. Ask them how they handled it. How did they approach the individual? Now, you may find that they just slept in a different room, and that's okay, that they couldn't handle it, or that's why they ended up being admitted to a facility. But again, communication with the family in this particular case can be very important to see the best ways to approach the person if they do have a REM sleep disorder. So Lewy body affects more men than women. People are primarily diagnosed after the age of 60. It's a shorter disease, so from onset of symptoms to death is about 7 to 8 years. Now, when we discuss behavioral management, Lewy body is an important disease process to keep in mind because these behaviors can be significant and, again, challenging to manage. Let's move on to vascular dementia, which also leads into mixed dementia. Our brain needs consistent blood flow to provide oxygen and nutrients to function properly. When that's interrupted, it can cause a vascular dementia. Most commonly, a stroke may block an artery, interrupting the blood flow. It can also be caused by other health conditions. According to the Mayo Clinic, risk factors such as diabetes, hypertension, high cholesterol, and smoking also increase the risk of vascular dementia. Unlike Alzheimer's, the impact of vascular dementia, meaning changes in function and behaviors, depends on what part of the brain is affected. Remember the picture of the right and the left side of the brain? If it's on the left, language and judgment may be affected. Now also think back to that picture of different parts of the brain, like the frontal lobe or the parietal lobe or the temporal lobe. If it's in those parts of the brain, different functions may be affected. So that's why it's really important to understand these different parts of the brain. Vascular dementia is more stepwise than slowly progressive dementias such as Alzheimer's or Lewy body. In fact, after a stroke, an individual may actually improve, stabilize, and stay at that level for quite a long time. However, if the blood flow is interrupted again, perhaps because of another stroke or TIAs or a series of small strokes, then they'll decline, but in a very stepwise fashion. A mixed dementia is when there's more than one disease process causing the issue. So this might be a combination of vascular disease and Alzheimer's disease, or other types of different disease processes happening in the brain at the same time. The last type of dementia that I want to talk about is frontotemporal dementia. It's a much less common form of dementia, happening in about 10 to maybe 20% of cases. It also occurs in a much younger population, so it can start when people are in their 40s and 50s, and oftentimes people die at a very young age from this disease process. So according to the Mayo Clinic, that we see signs and symptoms of frontotemporal dementia can be different from one individual to the next. But let me tell you some common things that I see, also mentioned by the Mayo Clinic, is that we see a lot of behavioral changes. We might see a lot of apathy, a lack of empathy for anybody else. We might see increasingly inappropriate social behavior, a lack of judgment, a loss of inhibition. So we also might see a repetitive compulsive behavior such as tapping or clapping or smacking of the lips, a decline in personal hygiene. So we see a change oftentimes in eating habits where they either eat too much or they might eat, inappropriate, inedible objects. There's a compulsivity to put things in your mouth. We also begin to see problems with speech and language and motor, such as tremors and rigidity and muscle spasms, poor coordination. We don't know exactly why this happens, but again, according to the Mayo Clinic, certain substances accumulate in the brain. What causes these changes, we don't always know. There could be genetic mutations that are linked to frontotemporal dementia, but when somebody has a FTD, the way that you approach them needs to be different as well, because the way they interpret their world is very different. They may lose that spatial awareness. Even though it's a different part of the brain, they still can lose that spatial awareness. There are, of course, many other types of dementia that I haven't addressed in the previous slides. Some of those might include traumatic brain injury with dementia, or multiple sclerosis with dementia, Down syndromes with dementia, primary progressive aphasia, and many, many more. Maggie and I, during the live webinar, are happy to talk about some of these other different types of dementia if you have had experience with them or currently have somebody in the facility with them, to talk about how that impacts an individual neurologically as well as their behaviors. Now that we've talked about the different types of dementia that you're likely to see at Homestead Manor, let's take a moment to see what brings an individual to live there. Maybe they're living alone and can no longer manage, or their family can no longer care for them at home. They might have nighttime wandering, or perhaps they've transferred from another facility. I'm going to guess that this one has happened to you on different occasions. There are behaviors that maybe no one mentioned prior to the person being admitted. To better care for the individual, it is important to understand, why did they come to live at Homestead Manor? So in conversations with some of the residents and or their families, you may want to tease this out a little bit, because it will help you understand and better care for your resident. So let's take a moment and see where we've come so far. So we've talked about disease processes, recognizing the differences between dementia subtypes, like Alzheimer's disease, Lewy body dementia, Parkinson's disease, vascular dementia, mixed dementia, and frontotemporal dementia. You're actually very unlikely to see the early symptoms, at least if you're at Homestead Manor. You might in your outside life, you might know people with early stages of dementia. But at Homestead Manor, by the time that they come to you, they're likely to be more along in whatever disease process they're experiencing. So next, we're going to move into the communication strategies to improve care. So again, our goals are to understand and identify the symptoms and behaviors of dementia and strategy to manage those behaviors. You may ask, why communication strategies? Because you want behavioral management techniques. Well, understanding the disease process, understanding what's happening in the brain, has now helped us understand how we can communicate with a person. That changes everything. And let me give you some examples as we move into the next slide. We've heard a lot about the different types of dementia so far. And as you might remember from listening to or watching the Alzheimer's video and listening about the different types of dementia, you can now understand how those neurologic diseases impact our ability to communicate. Well, it's not only speaking, it's also about learning and how it impacts all of our senses as well that are controlled in our brain. So let's talk about our 5 senses. So first there's auditory processing, and as we remember from the Alzheimer's video, is that it's all about learning and memory. Then there's sensation and movement, how we are in our world, our spatial awareness. We have that visual ability that is impacted by the disease process, as well as perhaps smell and taste later on in the disease. Now, I do want to talk about the last 3 for a moment, because that may or may not be connected to the disease process or whatever is happening in their brain neurologically. With many people that you see, they have eye disease. Now, they may have cataracts that have been removed, but many people have glaucoma, where they go blind or virtually blind. They may be able to see white and dark, and that's about it. Or they may have macular degeneration. That may be in combination to having a dementia, or it may be completely separate. Maybe the person doesn't have a dementia, but it does impact their ability to communicate when they can't see, which can also change their mood. So this also goes along with smell and taste. Oftentimes as people age, they lose their ability to smell things or to taste as well. And so they may go for things that are sweeter because they can actually taste it. So whether or not a person has a dementia, the last 3 senses may be absolutely involved in mood and or behavior. But if we look just down at dementia and we take all those 5 senses, then how they communicate with us is very different. How they understand us, how they remember things, how they interact within their own environment is very different. So we need to figure out ways to better determine how to deal with the behaviors that an individual is having, or perhaps just how they're responding to us. We need to figure out a way to better communicate with them. Typically at this point, if we were doing a live format, I would be showing you some videos and talking about kind of a good, better, best way to manage those situations. Because of licensing agreement in YouTube, I can't show you the videos pre-recorded. What I may do in the webinar format is show you some videos to give a better demonstration. But at this point, what we've done is we've taken some examples from some of your residents that have been provided to us, and we're going to talk about the behaviors and talk about ways that perhaps you can better manage these behaviors, better communicate with the individual. Okay? So, just so you know, I don't know any of these people, any of your residents. We haven't been given anything but their gender by a Mr. or Mrs. and the initial of their first name. So you're going to know who these people are. And so that's going to be a really good thing for you guys to talk about afterwards in regards to the situations. We're going to start with Mrs. C. She has dementia. We don't know what the diagnosis is, but she's very aggressive and agitated in the morning. Before we introduce behavioral management techniques for Mrs. C, I want to introduce you to ACE. ACE stands for Assess, Create, and Evaluate. The goal is to get you to act before you react, to de-escalate the situation or even prevent the situation completely. So we're going to start with assess, which looks at the physical setting, the patient's functional status, environment, her medical conditions, and her emotional status. So let's move on with assess, and then we'll come back to create and evaluate. Assess is all about decoding the situation. And I'm going to go more into depth with this about Mrs. C, but we're going to look at the context and of what's going on. Are there any physical issues? And are there functional issues or environmental problems or medical issues that are happening? Is the person having an emotional response that is increasing this problematic behavior? One of the very important concepts in assess is to take a 360-degree view. See it from the patient's perspective or your resident's perspective, not just from your perspective. You know that she gets agitated in the morning, but let's look at it from her perspective. So let's start out with context. This is the who, what, when, and where of the situation. So who is it happening to? Well, we know that Mrs. C has dementia. We know that this is happening to her, but who else is it happening to? Is it happening to other residents? Meaning is she getting involved with other residents? What is happening with the situation? Is she talking to another resident, or that is she coming out of her room and very agitated, or is she talking to a nurse and very agitated? Is she having to take her medications and very agitated? We want to look at the what is happening when she's agitated. When is happening? Well, we know it's in the morning. However, when in the morning is it? Is it happening before breakfast? Is it happening after breakfast? The reason for that is she hungry? Does she need a quick snack? Does she need a cup of tea or a cup of coffee right away? Does she need her medications right away? When is it happening in the scheme of things in the morning? If it's happening after breakfast, is she getting enough to eat? Is she have an upset stomach? Does she have some sort of acid reflux that she's getting agitated by? And where is it happening? If it's in the morning, if it's early in the morning when she first gets up, is it happening in her room? Is it happening in a common room? Okay, so in that who, what, when, and where, the context of it, you need to take a look around and see what's going on in that moment, so you can now figure out, okay, this is a piece of the puzzle. This is a piece of the communication problems or the communication strategies we need to work on. So next is physical. Is she in pain? Does she have arthritis where it's really difficult for her to get up and moving in the morning, and you have your list of things to do to get her dressed and to get her moving in the morning? Is she in pain? Is she injured? Now, in this particular case, she's probably not injured, but in general situations, you may want to look at that as well. Is there something going on that she's not telling you? Is she diabetic and she has an injury on her foot that she can feel but she can't describe? Is she tired? So if this is happening in the morning and she's waking up, is she have early morning awakening, or is she not sleeping well during the night? And this is where communication between night shift and day shift is very important as well. You need to understand what's happening in her sleep patterns. And for example, does she have Lewy body dementia? So if she has a REM sleep disorder and she's very restless all night, she may be very agitated in the morning. Functional plays into also the context, right? So toileting, hungry, thirsty, hot or cold. If it's first thing in the morning and she needs to toilet, but she can't describe how she needs to do that or what she needs to do, or if she's really hungry because she didn't eat well the night before, or perhaps she's very thirsty, or she's not dressed appropriately, so she's getting agitated. What is her functional status, and how can she describe that? That's an important piece of this puzzle as well. So determining the person's functional status and what they may or may not be able to describe to you is part of that communication strategy. Environmental may surprise you. And this, again, is a really important thing to take a 360-degree view of. So I'll give you a couple of examples. Sometimes things are very bright in a facility. All the lights get turned on. You may go in the person's room and you flip on the light, the overhead light, and that may just unnerve them and make them very agitated. Or the light may be very bright in the facility as general. Or, on the flip side of it, it may be very dark. So if they have macular degeneration or they have glaucoma, they may not be able to see as well. Is it very noisy? Is there another resident who makes a lot of noise? Sometimes after people have had strokes, they tend to scream or they call out. It's not their fault. It's beyond their control because it's because of their own dementia. But is that disturbing Mrs. C? Are there any safety factors? Now, I would imagine that Homestead Manor is a very safe place to live and you've reduced all of those things. But again, take a 360-degree view of her environment. Is there anything that's causing her to be disturbed? Medical is actually pretty self-explanatory, right? So, if she's doing this consistently at the same time every day, it's very unlikely that she has some sort of injury. However, it's always good to take a look to do an examination of the individual just to make sure that they don't have an injury, they don't have an infection, they don't have medical problems such as urinary tract infection. Now, I know that you all deal with this all the time with urinary tract infections, but I just want to remind you that urinary tract infections and other types of infections can cause a sudden change in behavior. So that sudden change in behavior can include hallucinations, delusions, increased agitation, things that is unusual for this person, and again, a sudden change. If the person has been out and come back, if they've been to the hospital and come back, or if they've even been out on a visit with family members and have come back, you want to make sure, again, that there's nothing medical that could have been happening while they were away from the facility. And the last part of assess is emotional. So this could be afraid, lonely, bored, depressed, all of those emotions that prior to having a dementia, the individual may have been able to manage those emotions. But as the diseases progress, whatever the disease is causing the dementia, their emotions may get bigger and they may not be able to manage those emotions in a way that are good for them or help reduce their loneliness or their fear or their boredom. I often will say, and this is where you can explore this with the families, did they have anxiety before they came? Sometimes when somebody has a lot of anxiety with dementia, it was actually present prior to them having dementia, but it's gotten bigger. I always like to say it's kind of blossomed like a sunflower, gotten very big, or been almost like it's been under a microscope and magnified. So you want to explore with the family, did they have emotional responses prior to them being in the facility or even before they got the dementia, and how did they manage that? It's really a good technique to know, to work with the families, because they can give you a lot of clues sometimes of how to best manage the behaviors the individual is experiencing. What I'd like you to do for a moment in your group is I'd like you to stop the video just temporarily, and I'd like you to talk about Mrs. C, if you all know her, and just go over this very briefly, and then we'll move on to tips to communicate more effectively, okay? If you didn't get a chance after the last slide to stop and talk about Mrs. C, I would really encourage you to do that before the next session, okay? Go back to look at Mrs. C and really look at everything that's going on, and talk among yourselves about what you're seeing, because you're each seeing something a little bit differently, right? But now let's talk about tips to communicate more effectively. The first thing is greet the person by name. Now, that may seem very simplistic, but looking Mrs. C in the eye, making eye contact and smiling, even if you don't feel like smiling, okay? But smile and greet her by name. Then you're going to assess the situation to understand what's happening at that moment. So again, when you look at Mrs. C, what you're looking at is what's going on in her world right now. Is she just upset to be upset? Maybe, but maybe not. Maybe there's something else that's going on. But remember that you're going to greet her by name, make eye contact at the same time that you're assessing exactly what's happening. You're going to meet her where she is. Now, how do you do this? That you're talking to her about the situation. You're not saying, oh, there's nothing going on, Mrs. C. You're empathizing with her for the moment. You're acknowledging that she's distressed. You're talking to her in a way that is empathetic but not condescending. What that means is that you can talk to her, that you understand what she's going through, but you're not trying to minimize what she's saying at the same time. Speak calmly and slowly. That is really important. What happens with an individual with dementia is that they will mimic where you are. So if you get really excited because she's really excited, then what's going to happen is you're just escalating the situation. So keep your voice low and speak slowly. Keep your hands at your side. Now, you guys can't see me, but I'm a person who talks with my hands. And this has been a particularly difficult thing for me to learn over the years. Sometimes I have to just hold my hands at my side, or make sure that I'm very conscious of where my hands are. Because again, remember that she is acting the way that you're acting. If you're wildly moving your hands, or if you're brushing her off, then she's going to get more agitated instead of less agitated. Remember, they may be reflecting your mood and your voice tone. If you walk away with anything, this is it. Less may be more. Less words. The reason I say less words is, remember, their auditory processing, no matter what the disease process that is going on, is damaged. If you use less words in a quieter, calmer voice, speak slowly and enunciate, you have a better chance of them understanding you. Don't argue. Don't try and reason with the individual. You can guide Mrs. C away from the situation, speak calmly to her, distract her, try and get her engaged in something else. But don't try and reason with her, because you're not going to win. That's just the bottom line. You are not going to win. What your goal is, and you have to keep this in mind, the goal is to de-escalate the situation, right? The goal is to even try and prevent the situation. So if you figure out what works best with Mrs. C, then you're going to be able to use that the next day and maybe even prevent it from happening, maybe tweaking it along the way. The last one is if a person has limited language skills, you can use hand gestures. So for example, instead of saying to them, go sit in the chair over there, what you're going to do is you're going to guide them gently with a hand movement, showing them the way to the chair. Now again, I know you can't see me do this. We will demonstrate this at the next opportunity. I may even do a short video with some of these things that we're talking about that you can do see in between, maybe a 3-minute video. But all of these things, I use them daily in my practice. Less words, quieter voice, speak slowly and enunciate. Don't try and argue or try and reason with them. Meet them where they are. Understand that they have this disease that is ravaging all the reasonable parts of their brain. Okay, so again, Mrs. C with dementia is very aggressive and agitated in the morning. Now that we've talked about the assess, how can we communicate more effectively with Mrs. C to reduce her morning agitation and or aggression? So it's not enough just to assess the situation. You have to create a plan. So this is where communication between the staff is also really critical. You need to determine as her caregivers what works and what doesn't work after you've assessed the situation. And then share that with your team members. Discuss it, document it. That's the way you're going to improve the care that you're giving to Mrs. C and perhaps even prevent some of the behaviors. Okay, so Mr. M has behaviors. He's very possessive over female residents that he thinks is his wife. He has hit residents when they have touched the females. He is exit seeking most of the time, thinks that it is his building and his property. He tries to get in other residents' rooms and gets very angry when we try and stop him. He then threatens the staff that he's going to hit them, although he has not hit staff, but just threatens. In regards to him being very possessive over female resident that he thinks is his wife, this is a really tough one that I would like to tease out with you guys a little bit more when we meet in a live webinar. But it's not uncommon for individuals who, who have a more advanced dementia to confuse other people, especially in this case, other residents, other female residents in his case, as his wife. The individual may have a similar build to his wife or have a similar appearance to his wife. If his wife is coming to visit, you might want to talk to her about this to sort of understand what their relationship was, and was he a very possessive person when in their marriage. Now this gets to be a little sensitive. I know that you guys aren't perhaps trained in this area, and you might want to bring in one of your psychiatric providers again to sort of help tease out some of those issues with his wife if you're not comfortable with it. But it is something that we can do together to tease out some of those behaviors. In the meantime, I'd like you to go over together those same ideas of context and physical and functional, environmental, medical, and emotional. Some of these may or may not pertain to the fact that he's possessive over a woman that he thinks is his wife. But it's still a good process to go through, because together as you're problem solving this, you may come up with some ideas that make sense that you can try together. I want you to go through that exact same strategy of the assess to look at the first part of Mr. M's behaviors. Mr. M is very possessive over female residents that he thinks is his wife. What is the context? We don't think it's probably physical, but it's the who, what, when, and where is probably the most important issue right now to assess, because when is it happening, what is happening, etc. And the emotional piece of it, he sees this woman as his wife, and so it's really figuring out, what is going on and what is his emotional response. With this situation where he's possessive over the other female resident, less may be more is really important. Again, less words, quieter voice. When he gets really angry, you stay really quiet. Keep your voice low and even. Speak slowly and enunciate. Don't try and argue or reason with him. And the gentle hand gestures probably are not needed for Mr. M. But again, if it's verbal skills or you're trying to guide him away from the individual, you can use those hand gestures to just gently guide him away. So let's start with Mr. M and his exit seeking. First, please do not try and argue or reason with Mr. M. It just doesn't work. Remember what we talked about when it came to the brain and how as the brain deteriorates, people lose that executive function, that ability to reason. And so what ends up happening is that people just argue. And then you try and argue back with them or reason back with him, and it's not pleasant for anybody, and it just doesn't work. So instead, let's focus on decoding the situation. I want to focus in on the context of the situation, the who, what, when, and where. Now, I want to start with when. In the email, it said he pretty much does it all day. Well, we need to understand that piece a little bit differently, why he's having that confusion that he's trying to exit seek all day. But let's take another view about when. Let's say we need to figure out what time of day is he doing this? So for example, is he doing it primarily in the morning when he might have been going off to work? Or is he doing it more in the evening when he might have had chores to do if he was a farmer? Is he doing it at another time of day because he was a delivery man and he had packages delivered throughout the day? This is why it's important to understand who was Mr. M as an individual, because as the brain deteriorates, those are the memories that people have. It's not what happened 5 minutes ago. It's who they were as an individual, perhaps 20 years ago, or 30 years ago, or 40 years ago. So those sorts of understanding about the individual, the context of the situation, but also the who, what, when, and where, meaning of their personal lives, could be impacting, in this case, exit seeking. Now, certainly, it's important to understand these other pieces as well. Emotional can promote exit seeking as well. Is he afraid? Is he lonely? Is he bored? So he might be afraid that a family member is in danger, or he might be confused about where he is, and afraid of where he is, so he's trying to exit seek. This is part decoding the situation, because what you do from there is you develop a plan of how to prevent it from happening based on all of the information that you put together. And it may be up to people on different shifts to determine, okay, well, he's exit seeking primarily at X time of day, 10 p.m. at night. What's going on at 10 p.m. at night in his life that he thinks he should be leaving the building. Now, this takes a little bit of investigative work, which I know that sometimes you feel like you don't have, but it can help prevent a lot of situations that will increase agitation on his part, frustration on your part, and it will keep the patient safer. So once again, let's talk about when he's exit seeking. Greet Mr. M by name, make eye contact and smile. Assess the situation to understand what's happening at that moment. Meet Mr. M where he is. And again, if we know that he had to bring the cows in from the field to start the milking process at a certain time, then you can talk about that. And speak calmly and slowly. Keep your hands at your side. Remember, they may be reflecting your mood and voice tone. Okay, so now with Mrs. C and Mr. M, you've assessed the situation, you've created a plan for each of them. Some of the things that you've come up with have been successful, some maybe have not. We're going to talk about this in the live webinar. However, now you need to evaluate those plans, okay? And so log the successes, have some sort of communication strategy between shifts, or if you talk to one another, or if you have some sort of log that you can communicate with one another. But understand what the successes and the challenges have been. Nothing works 100% of the time. It just doesn't. But sometimes in some situations, one thing will work, and sometimes in another situation, another thing will work. Implement those changes, and you have to be consistent about it. Review them with your team. Support your team members. Remember, you all have the same goal: to take good care of your residents, to give them a quality life. And to do that, you and your team members need to support one another as well. Okay, so I'm just going to spend a couple of minutes on communicating with the family. They're an integral part of having a resident at Homestead Manor. Sometimes you see the family more, sometimes you don't see them much at all, sometimes you speak with them on the phone, sometimes you don't. But it is an important piece of the puzzle in how to communicate with the family and the better care of your resident. So basically, communicating with the family, you're going to use the exact same assess tool as you did for the individual. Look at from the family's 360-degree perspective. What's going on? Are they afraid for their loved one? Are they grieving the long progressive dementia that's occurring? This is not the person that they've known for however long they've known them, either their entire married lives or for their children, this is their parent. It's very sad for them. And also the behaviors may be embarrassing for them or trigger some memories for them from their childhood or from their married life. So you have to understand where the family is coming from when some of these things occur. Use those same tools that you learned from using with the resident. Again, looking at it from their perspective, from their view, helps you understand how to better communicate with the family. They can be an incredible resource for you, providing information about the individual when they were younger, before they had this disease. Okay, so that ends my portion of the program. Now Maggie's going to join us and talk about mindfulness and resilience.
Now we're going to talk about mindfulness and resilience. I know you've all heard the word mindfulness a great deal because everyone is talking these days about mindfulness and meditation and how those things can be helpful. What is resilience, though? According to the American Psychological Association, resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. It means bouncing back from difficult experiences. Lots of us are facing stressors across many of these things. It's not just a family problem. It's not just a serious health problem. It's not just a workplace problem. We might have problems across all of these things. And what we need to do is learn to apply strategies and tools so that we can bounce back even when there are multiple stressors coming at us. We're going to talk about the brain a little bit now to understand these concepts more, specifically the amygdala and the hippocampus in our brains. The amygdala is part of the limbic system. It generates emotions, stores emotional memories, and provides emotional meaning in day-to-day life. So you heard me using the word emotion a lot. Emotions are quick, right? We tend to experience anger quickly. We tend to experience joy quickly. So our emotions tend to just happen like that. So we want to think about our amygdala as quick to react. Our hippocampus is also part of the limbic system, and it is responsible for storing new memories. So a lot of the residents that you might be challenged by have a damaged or pretty non-functional hippocampus. When we have some kind of a dementia syndrome, our hippocampus often doesn't work or works pretty poorly, so it's hard to store new memories. Our amygdala draws on other parts of our brain, including the hippocampus, to understand what's going on. This is important because it sometimes doesn't read the situation correctly because it is so quick to react, and it's what we draw on when we are responding to an emergency situation. So if there's a fire, it's our amygdala that's going to tell us you have to get out right now. So it's going to be more likely to interpret danger to keep us safe, even when danger is not there. Now, why is this important? This is important because there's something called the amygdala hijack. This is if we allow our emotions to run the show all the time. For example, if you have a resident who reminds you of someone who has always just really triggered anger in you, and you allow this resident to kind of trigger anger in you all the time at work, that's called an amygdala hijack. An example in my life, I have a teenage son who, it might not surprise you to know, can use sometimes a sarcastic or disrespectful tone with me. He uses a phrase that I hear quite a bit, you're so annoying. So what if I was working and I had a resident who used that word annoying or had that same kind of tone of voice when speaking to me, and I found myself getting really irritable and angry, kind of not, not in a way that matched up with what was really going on. My amygdala is drawing on that memory that I have, and that's what's drawing up my anger. So it might not be the present situation. You might be triggered by something that happened in the past, and the present situation reminds you of that. So that's something to be mindful of. Those things can chip away at our resilience and our ability to handle situations calmly. So it's worthwhile to kind of step back when we're particularly challenged by one resident and say, now, what is it about this person that seems to trigger this response in me? Why do I seem to get particularly irritable or angry or short-tempered, not necessarily on the outside, but on the inside with this person? What's going on? What might my brain be drawing on? So that's important to think about. Also important to remember that our brain has neurological tracks. So if we are someone who tends to dwell in the negative all the time, so we get up in the morning, we say, oh, I'm so tired. Oh, I don't want to get up. Oh my gosh, I got to go to work. Our brain develops neurological tracks, and then that's where our thoughts tend to go more easily. On the flip side of that, when we're more mindful of the positive, then those neurological tracks are developed. So if we tend to keep a gratitude journal, for example, if we tend to wake up and even if we didn't get the amount of sleep we wanted, we say, hey, it's a new day, the sun's shining, something that we're grateful for to be getting out of bed. Our brain develops those tracks, and then we tend to lean more that way. Our brains just tend to go more in a positive direction if we lean it that way as much as possible in our day-to-day thoughts. So thinking about at work with your residents, the more we're able to respond calmly and kindly in even the most stressful situations, the easier that will become. So it's like a muscle. When we're able to use these strategies that we're going to talk about to remain calm and level with our residents, it becomes easier over time. So here's where it gets a little bit tricky, because when the amygdala wants to take over, the amygdala does it fast because it's the part of our brain, as I said, that tells us if we're not safe, if there's an emergency. So it will be very quick, and it kind of derails our rational mind, which is the front part of our brains. Our frontal lobe is our planning, reasoning, and judgment part of our brains. And when the amygdala is active, those rational parts tend to go offline. So how do we allow our rational mind a voice too, so that we build our resilience rather than chipping away at it? Well, we need to do that in calmer moments. So we need to kind of step back at times like this when we're learning and thinking about these things, not in the moment, and think about our emotional and cognitive habits that tend to build resilience or chip away at our resilience. Okay, so what are some cognitive habits that tend to chip away at resilience? There are lots of them. We all have our traps that we fall into. I'm going to give a couple examples. I encourage you guys to talk about examples of the traps that you fall into, because noticing those cognitive habits that we tend to fall into that chip away at our resilience, just noticing them is more than half the battle. Because in noticing them, we're more than halfway there to letting those habits go. So one example is jumping to conclusions. The example I gave is, something happens in the morning with a resident and you say, well, that's it, the whole day is ruined in your mind. And when we do that, we tend to see the rest of the day through a negative lens. And when we look for negative things, we're going to find them, right? Because there are negative things. The other side of that coin is when we look for the positive and we have that positive outlook, we're going to find that too. There's a mindfulness concept called holding things lightly, meaning you're not going to allow yourself to get bowled over by every bad thing that happens. You're just going to kind of try to have that, oh well, and let it roll off, go on with your day, and continue to look for the positive, rather than, oh my God, this is the worst, I can't believe this happened, and really getting mired down in the negative. The other example I gave is magnifying and minimizing, magnifying the negative, minimizing the positive. Now, our brains do have a negativity bias. That comes way back from the days when we were, running from saber-toothed tigers, and our brains had to constantly look for danger to keep us alive. Now, most of us really aren't in those types of situations day to day anymore, but our brains still do have that bias where we're always kind of scanning for the negative. So it's up to us to be very intentional about magnifying the positive and turning our mental spotlight towards the positive. And again, like these other things I've talked about, it's like a muscle. It does get stronger the more you practice it. And when we kind of do the opposite of magnifying the negative and minimizing the positive, when we reverse that, we really tend to have more resilience day to day. So we talked about some cognitive habits that can chip away at resilience. What are habits that we know change our brains for the better and build resilience? Where there's two things that we know change our brains, actually physically change our brains when we do them over time, and build resilience, help us have a more level outlook, a more calm approach to life. Those two things are mindfulness and exercise. So no magic wand here. moving and doing some kind of mindfulness practice. Now, when I say a mindfulness practice, I don't mean necessarily sitting on a pillow, chanting Om with a candle. It doesn't have to be that. You see this woman in the picture, she's doing some yoga, she's outside in nature. That's a mindfulness practice. Starting the day with 1 minute of breathing and being mindful of our breath, maybe doing those longer exhales that we'll talk about in a minute. That's a mindfulness practice. So you can actually change your brain, build your resilience with as little as 1 minute a day. It can be that simple. Now, of course, I encourage you to do a little bit more, but to start, if you've never done any kind of mindfulness practice, I really would start with 1 to 3 minutes of just being mindful of your breath. There's a couple apps that we can share with you that we tend to use and our clients tend to use for mindfulness practices. One is called Headspace. Another is called Insight Timer. Another is called Calm. So, I mean, if you Google meditation apps, you can come up with a lot of them. Those are three that I've heard good things about. I use Headspace myself, and I start the day with probably a 3 minute meditation. I don't have much more time for that, but I really do think it makes a difference in my life. When I talk about exercise, I'm not talking about going to the gym for 3 hours a day. I'm talking about going for a 10-minute walk. Research shows that a 10-minute walk 3 times a week is shown to have the same effects on our moods and on our brains as an antidepressant does. So I'm not talking about a huge exercise routine, just going outside and going for a 10-minute walk. And if you do that habitually, it can really make a difference. Okay, so what if we don't have time for that 10-minute walk? I want to give you a few ideas for some quick recharges. And by quick, I'm talking about 1 to 3 minutes. If you're at work and everything's hitting the fan and you're stressed and you feel like you are not going to be your best self, what are some very quick strategies you can apply that will help soothe your nervous system and bring you back feeling calm and ready to tackle the challenges you have in front of you? So here are 3 things that you can do to reset your brain in less than 5 minutes. The first is just take 5 deep breaths, and you're going to do a longer exhale each time. That longer exhale activates the parasympathetic nervous system. That's the calming side of our nervous system. And when our parasympathetic nervous system is active, it's telling our amygdala to stand down. It's not an emergency. It's okay. It's okay to be calm. So an example that I gave is you're going to breathe in for a count of 4 and breathe out for a count of 6 to 8. That's just an example. You want to do whatever works for you. Some people like to count, so they'll actually count in their head as they breathe in to 4 and then breathe out for a count of 6 to 8. Some people don't want to count, but they just know they're doing a longer exhale. Figure out what works for you. Another one is stepping outside for 3 minutes and looking toward the horizon. That sounds totally weird, right? And we don't understand how this works exactly, but looking toward the horizon tends to get us out of the center of our brains. So when the center part, like the inside part of our brain, is active, we tend to be thinking about ourselves, comparing ourselves to others. It tends to be kind of a negative thing when only that part of our brain is active. When we're active in the outer parts of our brains, we tend to be more big picture. So we might realize, okay, this is a tough day, but this isn't going to matter so much in a matter of days or weeks. So we tend to be able to hold things lightly, like I talked about before. If you can't get outside, try to look out a window and look toward the horizon, look at trees. That tends to get us to that outer part of our brain as well. The last one I gave is noticing when you're doing any of the following: overreacting to little things, holding grudges against colleagues, against residents, drowning in guilt. We're all going to make mistakes. The job that you all do is extremely difficult and extremely stressful, so you're not going to be perfect. When we drown in guilt because of mistakes we've made, it doesn't help us to move forward. Dwelling on things long past, so things that have already happened and you can't control. worrying about stuff you can't control, mentally rehashing conversations or situations. When you notice any of these things are happening, acknowledge it. Don't try to resist it. Don't try to make it go away. Just acknowledge it, sit with it for a little bit. And I'm not talking about days, I'm talking about a few minutes. And then release. Release the guilt, release the grudge, putting it down. Some people are helped by imagining putting a rock down. So carrying these things does not help us like our jobs, like ourselves, do things in a way that makes us feel good about the work we do. Hi again. Thank you so much for watching all of that. I hope you got a lot out of it. I really hope you wrote down questions about your residents, and if you didn't, please do that now. Beth and I hope to produce some little videos showing some of the approaches that Beth talked about in the video, in the webinar. And then we hope to schedule a webinar where we can answer your questions live. So write down some questions, talk to each other, talk about what you think would work, what wouldn't work, and those really challenging residents that you're having a tough time with right now. Okay?
And we really look forward to seeing you soon.
Thank you.